Hello everyone, in today's video I'm going to talk about STEMI, that is ST elevated MI. We already have the knowledge of heart attack or myocardial infarction. So, if the patient comes with the complaint of angina, that is retrosternal chest pain, which will be radiating to arm or jaw or the back. Here the back means the upper back, and it is associated with profuse sweating. It could be like from the starting point of pain. So, sweating, nausea, and shortness of breath, that is breathing difficulty or dizziness. It is the classical symptom of MI. So, these are the pain points if you can see, and I will even tag the symptoms. So, if the patient comes with all these symptoms, you have to take immediate ECG. So once you take the ECG, you should focus on ST segment. So you can see the ST segment in normal ECG and the ST elevation in case of MI. So this is ST elevation. So what you should focus on? The elevation. So in men who are below 40 years, the elevation should be more than or equal to 2 millimeter. But in case of men who are above 40 years, it should be more than or equal to 2.5 millimeter. And in case of women, it should be more than or equal to 1.5 millimeter in lead V2 and V3. And in other leads, it should be more than or equal to 1 millimeter. In this case, there is only one choice, that is you should advise patient immediate stenting, shift to the higher center with the loading dose, or inform the cardiologist in a multi-specialty hospital if you are working. These are the types of ST elevation you should focus on in an ECG. So, which wall is affected with the MI? If you see ST elevation in lead 2, 3 and AVF, it is inferior wall MI. The inferior wall is affected. If you see ST elevation in V1 and V2, it is septal wall MI, and if V3, V4, it is anterior wall MI, and V5, V6, 1 and AVL ST elevation is lateral wall MI. V7 to V9 ST elevation is posterior wall MI. If you want to know how to take posterior wall detecting ECG, please let me know in the comment section. Along with this, you need to focus on ST depression, which is called as reciprocal changes in the ECG, which will confirm the immediate heart attack or acute heart attack. So the reciprocal changes are seen as below. If it is inferior wall MI, the ST depression will be in 1 and AVL. And in case of septal wall MI, the ST depression will be in the anterior lead, that is 2, 3 and AVF. And in case of anterior wall MI, we will not find any reciprocal changes because we can't see the posterior lead, as you know. And if in case of lateral wall MI, we will see the ST depression in 2, 3 AVF, that is the inferior leads. So these are the thing. How do you manage it clinically? So there is something called as loading dose, which you need to give the patient immediately if you find out these changes in the ECG, and you should not hurry up for the HS tropi. So if you want to shift the patient to the higher center, you should give tab disprin of 325 mg, tab ticagrelor of 180 mg, and tab atorvastatin of 80 mg. These three tablets you need to give immediately. If disprin is not available, you can go for ecosprin, but ecosprin will be having coating on it, which takes time to get in the stomach and dissolve. So we always prefer disprin. And instead of ticagrelor, you can give the clopidogrel, and obviously instead of atorva, you can give the rosuvastatin. In the loading dose, it is advised to give the anticoagulant. You can use the heparin or the low molecular heparin, that is Clexane. But this anticoagulant have the high risk of bleeding if the patient have any history of bleeding disorders or ulcers. So it is to be given with the advice of the cardiologist. So as a doctor, now you know how to manage an MI clinically. Thank you.